Test. Check.
Okay. Let's do a real quick sound check. Can you guys hear me out there okay? Give me a thumbs up or a text back.
Yes, we can.
Okay, we're doing good.
Can you hear me as well? Can you hear me?
Yes.
Test.
Yep.
Yep,
Okay.
we're good. Okay, well, I'm Ross Fowkes. I'm here with St. Mark's Hospital, our St. Mark's education that we do monthly. We have Daniel Carson here today to do a presentation on management of acute pain exacerbation in Suboxone patients for the pre-hospital. This will be a good one. We have a bunch of crews in the room here getting lunch, so they'll be a little bit noisy as we start, but shouldn't affect you too much. So with that, we'll turn the time over to you.
All right.
And go from there.
Okay. I'm gonna test this really quick and see. Is this supposed to work if I click it?
I'll get back to it.
Okay.
Right there. Good for you.
Yep. Okay. Well, thank you so much for having me here. Let me join you all today. My name is Daniel Carson. I am a physician in physical medicine and rehabilitation with a fellowship in interventional spine and pain management. I currently work at the Spine Institute of Utah. And so just first of all, a big thank you to each of you. You know, you're often the first line of you know, that first step in somebody's, you know, traumatic experience, helping stabilize things and taking care of them in really crucial a crucial time. And it's often in very high stress situations. And so thank you. And a lot of personal meaning and importance to me. Just a few months ago, my mom found my dad unconscious in the early hours of the morning. Called 911. EMS providers were very quick, and though he passed, they were able to get a heartbeat back quick enough that he was able to be an organ donor and bless the lives of others. And so, you know, that wouldn't have been possible without the special training that all of you have. So once again, thank you. So I'm a physical medicine and rehabilitation specialist. Sometimes they shorten it to PM&R. Sometimes they shorten it to, or they call it physiatry. And you know, it's interesting. Like if you say pediatrician, somebody has a pretty good idea of what you do, or orthopedic surgeon, somebody has a pretty good idea what you do, or a psychiatrist, or an emergency medicine physician. There's so many shows on internal medicine and general surgery, like Grey's Anatomy and Scrubs and House and all these different, you know, primetime TV shows. But nobody really knows what physical medicine and rehabilitation is. Even my own family, they're like, so what do you do exactly? So it's a mixture of orthopedics, where we work with bones, joints, and muscles. And it's also a mixture of neurology, where we work with the brain, the spinal cord, and nerves, with the primary goal of being function. All right. So our patient population: spinal cord injuries, traumatic brain injuries, strokes, amputees, sports-related injuries, pain and pain-related conditions. Again, all with the goal of function. So if somebody traumatically loses an arm, okay, then what? How can we make their life, you know, how can they function? So that's what this specialty is. And we're all kind of part of this big team, though we are involved in it in different periods of the timeline of this patient. So for example, you know, there's some sort of initial accident or trauma, and that's where you are. You're right there, first line, stabilizing the patient and getting them to a hospital setting. And then there in the hospital setting, there's a trauma that's called in the hospital, and then all hands are on deck, and they all come to the emergency department, and they triage the patient, and they do this assessment where they think, all right, or they figure out what needs to be done. Oftentimes that includes sending them off into surgery, whether that's with orthopedic surgery for, you know, different types of fractures, neurosurgery if there's like brain or spinal cord injuries, or, you know, just kind of general trauma surgery. And then all of a sudden the dust settles, and we're days or a week after they're, you know, essentially kind of things have stabilized, but their whole lives are totally changed. And so that's where physical medicine and rehabilitation comes in, where, oh, thanks for being here. But for a few weeks to a few months, these individuals will go to a inpatient rehabilitation facility and relearn how to walk, or to get dressed, relearn how to bathe themselves, relearn how to eat. And sometimes they can't relearn how to do those things, and it's a matter of learning a new way to do it, adapting to kind of their new way of life, whether that's learning how to use a wheelchair or learning how to use prosthetics. I wanted to share this with you because oftentimes in your setting of that timeline, I'm sure things just look very dire. And then you hand them off, and then you're off onto the next call like we saw here. And you don't really get to see what happens next. And so I wanted to share with you a few things. This is a program done through the University of Utah, the TRAILS program, where individuals with really, really extensive injuries, including high C spinal cord injuries, quadriplegics, they can't use their arms, their legs, can't even breathe on their own. They need a ventilator to breathe. What this program has done is it's developed equipment that has allowed these individuals to go out and be in nature. And in this particular setting, they have full control over this sailboat. If you see right here, this individual has this little apparatus that twists around and comes to their mouth, and it utilizes sip and puff technology, where literally with either blowing air into this straw or sucking air out of it, they're able to control the sailboat. And so they're able to get out there on the lake, have passengers on there, and just have full control over that sailboat, even with really extensive injuries. This is another example. This is called the Tetra ski. Same technology. They can either use a joystick or that sip and puff technology to have full control over this ski machine, where they're able to go and go up to the mountains and ski.
I'll get back to you.
Oh, you're okay.
They couldn't see you online.
And then they also have lots of adaptive equipment for individuals who can use their extremities, but just not very well. So a lot of power-assisted technology. Anyway, I just wanted to share that little bit with you, just because, again, oftentimes when you're handing them off, you may not know kind of how things turn out. And that's not the case every time, but oftentimes these people are, even with extensive injuries, are able to go on and live just really happy, fulfilling lives, and able to get out and do a lot of things, even if that requires some adaptation. All right. So today, we're just going to briefly talk about pain management in a patient that is on Suboxone. Pain is a difficult thing to try to treat in the acute setting. It can be a difficult thing to treat in the chronic setting. It can be especially tricky when it's an acute on chronic. And it can particularly be challenging when somebody's on a medication like Suboxone. So the objectives today is to kind of just understand, like, all right, what is Suboxone? How does it work in the body? Identify some safe and effective pain management strategies, and then just kind of, if there's time, have some open discussion as far as challenges and maybe some misconceptions in the setting of Suboxone. All right, so kind of starting at square one. What is pain, and why on earth do we even have to experience pain? Well, pain is a very important safety mechanism. You could imagine what it would be like living a life without pain. If something happens that's damaging and you don't know about it, then that could lead to a lot of issues. So just picture some common things that you may encounter, like a heart attack. We often know that they're diaphoretic. They may have nausea, vomiting, and then some really intense chest pain or chest pressure. Well, if we take the pain out of that and they just start sweating a little bit, there's not that alarm system for the body to be like, hey, something's going on, let's get some help. Or if somebody's having appendicitis and there's no pain associated with that, they're just kind of like, I just feel kind of yucky. There's nothing to alarm their body that something intense is about to happen and that they need to seek help. Pain has that a safety. It's part of the safety mechanism. And you can imagine, like, without without pain, we wouldn't have those safety mechanisms, and it could lead to further damage and potentially even death. All right, so how does pain work? Well, it starts off with some initial noxious stimuli or damage to tissue or a bone or something. And it activates pain nerve fibers, and those pain nerve fibers send a signal up the nerve. It hits the spinal cord, travels up the back of the spinal cord into the brain, where then the brain interprets the pain. What happens after that? Well, the brain actually releases a natural opioid that the brain makes. The brain makes an opioid, it releases it, and then this opioid molecule attaches to this opioid receptor, and then what the reaction is it actually turns down that pain nerve signal. So the opioid attaches to the receptor and then calms down those nerves, making the pain feel a little bit better. And then after that, the dopamine levels in your body rise. And dopamine is your body's natural kind of feel-good chemical. And that's what happens on a daily basis. You stub your toe, or you cut yourself, or something happens. This process is just constantly happening. All right, so what is an opiate? Well, an opiate, it's a man-made or synthetic molecule that attaches to the exact same receptor. And then it causes a very similar reaction. Turns down the pain fibers, and then afterwards there's this surge of dopamine released, making you feel good. And there's a lot of different kinds of opiates: fentanyl, morphine, heroin, hydromorphone, hydrocodone, oxycodone. And then there's brand names like Vicodin or Norco, where they take an opioid and they mix it with Tylenol and they put it in the same tablet. Oxycontin, Percocet. So lots of different types of opiates. Let's go over some pharmacology just really quick, because it sets a really good foundation of what we're going to be talking about today. There's this term called affinity, and a really simple way to think about affinity is the strength to which this molecule is able to attach to the receptor. So if something has a very high affinity, it binds very strongly to that receptor and won't let go. If something has a low affinity, it binds weakly to that receptor, and it doesn't take much to kick it off. So if you have two molecules that both attach to the same receptor, the one with a higher affinity is going to win. Now, can that be overcome? Can this strong molecule ever be pushed out? The answer is yes, but what it takes is to really dump a lot of these weaker molecules into the system, and then if you have enough, it can kick that stronger molecule out. We call that competitive binding. Another concept we need to understand is something called intrinsic activity. So we talked about what happens up here. Now let's talk about what happens inside the cell. Sometimes the response can be really, really strong. Other times, when the signal is started, it creates a very weak response, or what we call a partial response. And there can be all sorts of different variations. You can have a strong molecule bind to the receptor, which produces a really strong response. Or you can have a really strong molecule bind to the receptor and just create a weak response. You can have a weak molecule bind to the receptor, creating a strong response, and all sorts of variations. And sometimes you can even have a molecule bind to the receptor and it completely deactivates or turns off the response. And so that is what we call an antagonist. Okay? So an agonist were all these other examples where it's turning something on in the cell, whether it's strong or weak, it's turning it on. In this case, an antagonist attaches to the same receptor but then deactivates the cell. And there's a reason why we're talking about all of this. It'll help make sense of what we're going to talk about next. Now, what's the difference between these opioid molecules that we make synthetically and the natural opioid that your brain produces? Well, there's a huge difference. Hydrocodone, which sometimes in the pain management world is kind of one of the lighter medications as far as opioids go, it's 20 to 30 times more powerful than the natural opioid that the brain makes. So these things are potent. They're really, really powerful. And there's a lot of changes that occur in the body when somebody takes these for an extended period of time. That deactivation of the nerves that we talked about before, well, in a chronic situation, when somebody's taking opioids chronically, those nerves lose the ability to kind of self-regulate. So without that constant tampering of the nerves, they're just kind of on fire. Additionally, the body will stop making and releasing dopamine unless there's an opiate on board. There's also those same receptors inside the GI system, which can cause constipation and a lot of bowel issues. All right, this is unfortunately something that you're probably familiar with. What does an opioid overdose look like? Well, you know, we just talked about how these opioids suppress the central nervous system. They suppress these nerves. Well, what happens is it's suppressed so much that the center in their brain that tells their body to breathe is suppressed, and then they stop breathing. So they present with acute respiratory failure. Oftentimes they'll have the pinpoint pupils. They'll be in a coma or loss of consciousness. Their heart will be really slow. They'll be pale and blue and cold because they're not able to circulate blood. And then what does withdrawal look like? Well, it's the opposite of all the things that an overdose looks like. So instead of those nerves being turned way down, those nerves are just going crazy. And what does that look like? Well, they'll have terrible, terrible muscle cramps and muscle pain because those nerve fibers are just on fire. Their GI system is going to be, you know, instead of having constipation, it's the total opposite. They present with like lots of diarrhea and loose bowels and terrible abdominal cramping, nausea and vomiting, their heart's racing. They have tons of goosebumps that is called cold turkey skin. And I believe that's where the term quitting cold turkey comes from. So when these people, you know, go through withdrawal, they get that cold turkey goosebumps skin. They salivate, they lacrimate, there's tears coming out of their eyes, they produce all sorts of mucus, and that's what withdrawal looks like. When does that typically start? Well, early symptoms can start as soon as 6 hours after their last dose or injection of heroin, for example. The earlier symptoms is that kind of anxiety and restlessness, the muscle aches, which is oftentimes why somebody who's addicted will quickly try to find kind of their next hit of whatever it is. The later symptoms can start 24 to 72 hours later, and that's where these really intense withdrawal symptoms of nausea, vomiting, the terrible pain, things like that will start to happen. This can last up to a week. So just really miserable for 5 to 7 days. And what's interesting is that even after the opioid is out of their body, withdrawal symptoms have settled down, their body's still not really releasing any dopamine because there's no opiate on board. And so now they're just kind of miserable. So as frustrating as it is, we can kind of get a little glimpse into how difficult it is just to stop something like heroin or other opioids. All right, now with this kind of basic foundation, let's talk about buprenorphine, which is the generic name for what is in Suboxone. I'll give you kind of the medical terms, but then we already talked about what this stuff means. So it's a partial opioid agonist, and it's used in opioid use disorder, but it can also be used in chronic pain management. All right, so we know what an agonist is. It's going to turn on something, but it only turns it on partially. So it's actually kind of a weak response. It has an extremely high affinity. So buprenorphine or Suboxone, it is one of the strongest things that can ever attach to this receptor. Stronger than fentanyl, stronger than morphine, stronger than oxycodone, stronger than heroin. Okay? So buprenorphine attaches to this receptor stronger than any other opioid. But once it attaches, again, it only halfway turns on the mechanism. It has what we call a ceiling effect, meaning, if this was something like morphine or fentanyl, it would have this huge effect, whereas buprenorphine, even if you add more and more and more and more buprenorphine, it's going to taper out at like 40% of what other opioids would do. And it comes in actually different forms. Suboxone is a really common one. What is Suboxone? Well, first of all, it's in a kind of a film that you just put in the side of your mouth, kind of between your cheek and your teeth. And it's a mixture of buprenorphine and naloxone, which is an antagonist. So this film has both the thing that activates the receptor and the thing that turns it off. That kind of seems weird. Like, why on earth would they make a medication with the thing that activates it and turns it off in the same medication? Well, when this is taken in, when the naloxone is taken in any other way than through either intranasally is probably the way you're most familiar with it, or injected, that's the only way it's going to be active. So if it goes through their GI system or is absorbed under their tongue, it's not going to be active. And so only the buprenorphine is going to be active in their body. And then if the reason why that's in there is the drug companies are just trying to get creative as far as, what if the individual is trying to abuse this and they melt it down into a solution and try to inject it? Well, that's when naloxone is going to go in and be active. There's other forms though. There's Subutex, which is a little pill, still just placed under the tongue and absorbed through the mouth, and Sublocade, which is a once-a-month injection that just goes under the skin and is released slowly throughout a 30-day period, and that's administered in a doctor's office. So different forms of buprenorphine. All right. Now, kind of the meat of this lecture is, all right, the implications in acute pain management. So we talked about buprenorphine, how it bonds very, very tightly, but then it only produces like a 40% effect, okay? And so if an individual who's on Suboxone were to then get in a car accident and break their arm or fall off of a ladder or, fill in the blank with any type of injury, it becomes really difficult to treat that individual's pain. Why is that? Well, all of these receptors that we typically, would use to treat pain with something like, morphine or fentanyl while they're, en route to the hospital. Well, now all those receptors are taken up by this super, super strong molecule buprenorphine. So it can be difficult to treat pain with patients on Suboxone.
Question for you.
Yes, please.
So what's the difference between that and methadone?
Really, really good question. So first of all, buprenorphine, we just mentioned, it binds really strong, but it only produces half of effect. So it's a partial agonist. Things like fentanyl, pretty much all the other opioids are full agonists, means they produce a full effect. All right, so that's one difference. Methadone is a full agonist. It's going to produce a full effect. Fentanyl, you give it through IV, it comes on with almost immediately. So within 10 seconds of pushing it, it's going to start activating in their body. But then it's going to come off really fast too. So it's active for maybe 30 minutes to 45 minutes before they need some more.
Okay.
Methadone is a long-acting opioid. So it doesn't rise as quickly in the body, but it stays around much, much, much longer. So again, like things like methadone clinics, sometimes they have the patient show up once a day, they take their pill, that opioid is now going to be active all day long, or 8 hours or so, and then they go back the next day and get more methadone. So yeah, methadone, long-acting opioid, whereas morphine, fentanyl, all these other ones are very short-acting, within 30 minutes to an hour, and then they're kind of out of the body.
Gotcha.
Great question. Because yeah, methadone is a common thing as well. Okay, so some of the misconceptions in managing somebody's pain who's on Suboxone. First of all, there's a belief that some people might believe that, well, oh, they're on Suboxone, so every single one of those receptors are taken up by Suboxone, so I can't use any opioids. That's not necessarily the case. On a normal standard dose of Suboxone, it only takes up about 75% of the receptors. So if that person does get in a car accident and has some sort of trauma that needs to be treated with opioids, it's still reasonable to try that. Sometimes there might be a belief of like a hesitation to use opioids because, oh, this person's on Suboxone, they must have been addicted. If I use an opioid to try to treat their pain, am I going to send them into some sort of relapse? And that's a misconception as well. It's appropriate in the case of severe pain to go ahead and treat with opioid. We'll go over more of that in just a little bit. It can be really hard in your setting as well because it's not like you have this nice calm time to take a nice thorough history and ask them, what types of medications are you on? And they're like, yeah, I'm on Suboxone. Like it can be difficult to obtain that information in the types of settings that you're in. And so that can be challenging. So what do we do? This is taken from a medical journal. ASAM is the American Society of Addiction Medicine, and they came up with these guidelines on how to treat patients that are on Suboxone. So here's kind of the key points and the key takeaways. Number one, continue the Suboxone, continue the buprenorphine. That may not be useful information in your setting because it's not like, if they're in the car and they get in an accident or something like that, that they're gonna pull it out and be like, should I take this or not? But just so you know that the correct answer is, in an acute pain exacerbation, advise them to continue taking Suboxone. It's not required to stop it. Number two is exercising a multimodal approach to treating their pain. Starting with things like IV acetaminophen, NSAIDs, ketamine, and then regional anesthesia, which you probably won't do much, but once they get to the hospital setting, we start using regional anesthesia, nerve blocks, things like that when feasible. How many of these things do you use like on a regular basis? What would you say? Toradol and ketamine. Okay. Yep. I love it. Okay. And the ketamine, do you give IV or intramuscular? Both. Okay. Is that kind of
for pen IV?
Yes, I think for crazy people undergoing mental health issues.
It's a pen, intramuscular. Yeah. Okay. Excuse me. Okay. Okay. And we'll go over some more about ketamine in here in a little bit. And then additional opioid analgesia. So it is appropriate, if you see fit, to go ahead and use some more opioids. So morphine or fentanyl. Understanding that it's not as straightforward as it would be in somebody who's not on Suboxone. So really kind of titrating, starting off low and slowly increasing until it's effective. I'm just going to go back to this picture here. So all those like fentanyl and morphine, they aren't as strong as buprenorphine. So sometimes you may find that it takes more opioid, more fentanyl, or more morphine than in a normal situation to treat this person's pain, which again makes it kind of it's a balancing act because we don't want to add so much that we're then causing acute respiratory failure. So it can be difficult, which is why those other options should be tried first. Let's see. So we got to here. All right. So what is ketamine? So ketamine, what's really nice about ketamine is that, this was our opioid receptor. And so buprenorphine, morphine, fentanyl, heroin, all those things attached to this receptor. Well, what's great about ketamine is it has its own receptor. It's an NMDA receptor. And so even if there's buprenorphine bound tightly to this opioid receptor, and we push something like ketamine, it can be extremely effective because it's not having to compete with that same receptor. It's able to produce its response through a totally different receptor. So both the multiple organizations, including the American Society of Regional Anesthesia and Pain Medicine, and these others, are in full support of utilizing ketamine, and especially in the buprenorphine population. Their guidelines, when we talked about this last week with another group, I think your guidelines might be a little bit different as far as how much you're able to administer. I think they had said it was like around 30 milligrams was maybe a max initial dose. Is that? Yeah.
Yeah.
Okay.
Yes.
Their recommendations was starting about a half milligram per kilogram. So a 150-pound individual would be 70 kilograms. So that would be 35 milligrams. But again, this is probably different situation. But it sounds like 30 milligrams is what you're able to push initially, and then you're able to start an infusion if needed after that. Is that correct?
That's up to each individual department and the
Okay.
medical director.
All right.
Yeah.
Okay. Things that can be really, if you're able to obtain information like, hey, this is a chronic pain patient or a addiction recovery patient, they're on Suboxone, that is really, really important information to be able to have during the handoff into the hospital. But again, it might not be information that you have readily available. Okay. This is just some interesting information as far as the time of onset of the medicines that you may come in contact with or push while you're in an acute setting. So like IV acetaminophen takes 5 to 10 minutes to be active, around an hour for PO. Fentanyl, this is where it's good to know. This is like almost immediate time of onset. IM, it's like 7 to 8 minutes before it's effective. Do you use nebulized fentanyl? I don't even know this. Okay. Intranasal, do you use?
Not on purpose.
Okay. Ketamine, within 30 seconds, it can be active. And I'm sure you've probably kind of seen that in the field. Morphine, 5 to 10 minutes before it's active. And I don't believe you use nitrous oxide, right? Okay. All right. Well, that's basically all I wanted to chat about today. I don't know in your particular demographic here in Salt Lake, if you've come across patients that are on Suboxone, if that's something that you've been familiar with already, and if it's just review here. I see some nodding heads. Yeah.
Around this area.
Yeah.
Close to the hospital.
Yeah.
So when we have patients on Suboxone or methadone, they usually turn around and illicitly use like benzodiazepines to like enhance it.
Yes.
When we go on patients that have OD'd on that because of the synergistic effect,
Mm-hmm.
and we treat them with Narcan, should we anticipate any like cardiovascular collapse or anything like that? Because my understanding, the way I was taught in school, was the only substance that you can die from withdrawals are like alcohol. So they just want to die when they're dope sick, right? So should we, when we start to get these weird ones, not just like heroin, should we anticipate any like
More life-threatening
Yeah.
withdrawal symptoms.
Yeah.
Yeah. So backing up, you're absolutely right. all those withdrawal symptoms that we went over here with opioids, whether that be heroin or something else, they suck, but they're not life-threatening. Now, if we were to talk about benzodiazepines or alcohol, which interestingly, I'm going to go back to these receptors. Ignore this, but this receptor here is an opioid receptor. Well, the receptor that a benzodiazepine attaches to is the exact same receptor that alcohol attaches to. And so benzos are just like an alcohol in a pill form, really. So yeah, people withdrawing from alcohol or benzos, those withdrawal symptoms can be life-threatening because of the seizures and things like that they can have.
Because we don't carry Romazicon or anything that will block out a benzodiazepine. We only carry effectively the antidote for opioids.
Okay.
So.
Yeah. So your question being like, if I
Could we
push,
anticipate them going to die if we give them Narcan and they've also taken a benzo?
no.
So, okay.
No. Yep. Again, so the Narcan is it can attach to, sorry, I'm thinking of naltrexone. You guys don't do naltrexone, correct? Which is what you can give
No, we just do
in the
naloxone.
benzo setting. Yeah, naloxone. So yeah,
We're good.
you're good.
So just give it to them and be like,
Yeah.
hospital's on the way.
Right. Yeah. Yep.
Cool.
So any benzo or alcohol withdrawal that may
Okay.
set in can be taken care of in a hospital setting. But yeah, definitely push the Narcan, get them breathing again.
Okay.
Yeah. Great questions though. Yeah, we'll go here and then over here.
So we commonly see people that are in the demographic of being users, but they might have not used that day. But because they're difficult, sometimes agencies give them lots of Narcan when they don't have opioids on board. Can you speak to that a bit? What happens then?
So if they were to use the Narcan?
Yeah, if somebody that doesn't have opioids in their system,
Mhm.
but is a chronic user, right? So they have they're maybe in like the beginning stages of withdrawal. Now all of a sudden gets 8 milligrams of Narcan.
So the Narcan would probably send them into withdrawal quicker, which I would think is something that they wouldn't want to experience. So are you finding that they're actually using that? Using
The
the
patients?
yeah,
They don't want it.
right.
The other agency wants to give it, and then they want to give it to us.
Oh, I see.
We're the recipient of somebody that just got 8 milligrams of Narcan that didn't need it.
Okay. All right. So kind of they're tapering off and then they were just given Narcan and then all of a sudden they're going through withdrawals and then you kind of show up with this person actively withdrawing.
Right.
Um,
Do you have a treatment or a suggestion what to do with those patients on our way to the hospital? Other than
not on the way to the hospital. Right. Yep. That's so in a controlled setting, not in your setting, but in a controlled setting, that's where buprenorphine can be really helpful because it can be given. It won't give them this heightened opioid response, but it can really stave off those withdrawal symptoms and make them feel much better. That's not something that you have access to, and so yeah, unfortunately, nothing to really give them. Do you have things like antiemetics, Zofran, things like that?
It seems to be non-effective.
Yeah, I would think wouldn't be effective, but otherwise there's really not. It's a difficult population to treat from a physical standpoint, but also a mental health standpoint. Yeah. Was there something over here?
Yeah, I had a question. So if a patient's on Suboxone and you do want to try,
That's for the people online.
and you do want to try an opioid to relieve
Mhm.
their pain, does fentanyl or morphine, is one of them a stronger agonist?
So fentanyl is the stronger agonist, and it binds stronger as well. So you'd probably have more. In your situation, are you able to kind of pick? Do you have both on board?
Yeah.
Yeah. Like we saw earlier, fentanyl will be faster acting, and it does have a stronger ability to bind. So probably that one. But yeah, there may not be that much of a difference, to be honest. Yeah. Good question. Not a great answer. Sorry. Yep. Yeah.
To jump onto his question,
Yeah.
I thought was good. Would you go to like ketamine then?
I would do ketamine first.
Because we have the option to do ketamine for these specific
Yep,
patients.
I would absolutely do ketamine first. I think it can be more effective in this situation with somebody on Suboxone, where you're not having to like really teeter on titrating that medication, but you can just push your normal amounts of ketamine. And with ketamine, there's no like synergistic effect or attenuating effect, meaning it's not going to be more effective or less effective. It should be the same. Yeah, really good questions.
What if they're in that demographic where we're fairly certain that they're using opioids regularly, but may or may not be taking Suboxone?
Mm-hmm.
We're still, because they've got a higher affinity, right, to the opioids, right? So maybe even staying away from that, whether they're on it or not.
Mm-hmm.
Would you agree?
Yeah. Yep. So in that setting where you're suspicious, like I wonder if they either recently or in the past have been a user, I'm just going to gear towards ketamine and stay away from opioids. Is that kind of your question?
Yeah. Or Toradol, yeah.
Yeah, Toradol, ketamine. Yeah, I think those are great options and would try those prior to opioids. Yep. Okay. All right. Wonderful questions. And again, thank you for all that you do. And thanks for having me here today. Yep. Thank you, Ross.
Hey, yeah. Thank you. Appreciate it. All right. Well, thanks for coming today. Appreciate you guys. Have a great day. See you.
Thanks, Ross.
Stop carrying the screen. Stops.
Well, let it get you for 20 minutes. Yeah.